Well, hello there, everybody. We are back. School is now in session. Can you guess what I have here? A fine little mug full of vodka. Um, Here we go. Healthcare. So, in keeping with our theme of the well, let's see how to start this off. Very early in the course, we learned about how markets work, how free markets work, the advantages of free markets, the advantages of regulated markets, the role of the state and the private sector in our economy, and we learned the difference between public goods and private goods, commodities and public goods, right? And so today we are going to put that set of concepts to work, applying them to understanding healthcare in the United States in the context of the COVID-19 pandemic and the way that the United States has sucked ass at handling it. And I don't mean the political ass sucking, although that has been striking. And I don't mean the broader supply chain ass sucking, and I don't mean the individual citizen ass sucking. All of these things have been bad, have been a sort of a very intense level of sucking with respect to that which is ass. But today we're talking about healthcare, and specifically we're going to talk about health insurance, and we're going to talk about hospitals. And we're going to try to learn how these two pieces of our healthcare system work together or conspire together to make our medical system, our healthcare system, less resilient, less effective, less able to respond to COVID-19. And so all these concepts that we've talked about, markets and liberalism and public and private goods, are going to come into play here. So I want to start by pointing out that among, what many folks would refer to as developed countries, what I like to call rich countries, I just think that's a little bit more straightforward. Among rich countries, the United States is arguably the only one that does not have free universal health care. That is to say, the United States is the only one that doesn't treat health care as a public good. I'm going to multitask for a hot second. I don't think I've ever done that. All right. Turning the volume down. There we go. So the United States is the only rich country in the world that does not treat healthcare like a public good, that does not provide free universal healthcare. So if you look at this map, for example, you'll see all of Europe, with the exception of what I think is Belarus, and all of Europe, all of East Asia, most of South America, well, maybe not most by geographic coverage standards, not most by country standards. I think we're looking at Brazil, Argentina, Chile, and Paraguay, or Uruguay, I'm not sure which one. But and then Canada, of course, and Australia. You can't really see Australia because it's behind my beautiful face, mate. But Australia too has free universal health care. But among these countries, the United States is the only one that doesn't, okay? And so what we want to start with today is a little bit of the history, the 20th century history, because, one of the things I've been enjoying doing in this class is those sort of deep historic dives into the 20th century, because I really feel like you can't understand where we are today, how we got here, without looking at the 20th century, the long 20th century, as Giovanni Arrighi called it. Okay. So reflect on why the United States. What's uniquely regrettable about the United States? Or if you're a diehard free marketeer, what's uniquely meritorious about the United States that explains why we're the only rich country in the world that doesn't treat healthcare like a public good? And then let's ask ourselves, as a sort of sub-question there, is that fact, the fact that we buy and sell healthcare in the United States, the fact that your access to healthcare is determined to a very large extent by your wealth and your income, does that help us understand why the United States has more COVID-19 cases per capita than any country in the world? Are these two things connected? I want to stop short of providing some sort of easy, simple, definitive answer to that question here today. But I do want us to ponder the ways in which these two phenomena feed off of one another. Okay, the ways in which the fact that we treat healthcare like a commodity and that we sucked at COVID, where do these two things intersect? All right. Deep historical dive. 1935 is the early New Deal era in the United States. The presidency of Franklin Delano Roosevelt, and it's a period of, in the wake of, and in some ways in the midst of the Great Depression, the New Deal is an effort to move us out of the Great Depression through welfare state programs. And it's in that moment that, for example, Social Security is created in the United States. And Social Security can basically be thought of as a pension system for everybody in the country. If you work, you pay into this system, and when you retire, you get a pension from it. And so that was, a big breakthrough. That was a very moment of welfare state accomplishment in the United States. About 10 years later, you have the establishment in Britain, and indeed throughout most of Western Europe around that same time, of national health systems. Public, free, universal health care. So every taxpayer pays into this system, and the system is free to every citizen, right? Is essentially what it is. It's the same. It's no different than what we have in the United States with respect to K through 12 education. It's public. Anyone can go. We all pay into it. So the same idea. In the 1940s in the United States, we were trying to recover from the war, and one of the pieces of that effort was a piece of legislation. I looked and I couldn't find the exact date, but it's early 1940s. A piece of legislation that exempted employers from paying taxes on health insurance provided to their employees. So it was essentially a tax exemption to incentivize employers to provide health insurance to their employees. And this was in part, actually not in part, this was almost entirely intended to allow employers to offer more competitive packages to employees in order to bolster employment. And that worked pretty well. And in part, to a large extent, it worked pretty well because in the middle of the 20th century in the United States, we had pretty strong labor unions. And I think about, I'm making this up now, but I want to say maybe about 60 or 70%. Don't quote me on that. Look it up because I'm not fully sure, but let's say like 60 or 70% of blue-collar work was unionized in the middle of the 20th century. So we had good unions. And because we had good unions, we were able to make certain that employer-sponsored health coverage was pretty good, right? And they were further incentivized by this tax loophole that allowed them a tax exemption for paying it. So by the 1960s, this program grew. I mean, when you think today, in 2020 in the United States, when you think of health insurance, you think that's a thing that I get through my work. That's just what you think. Now maybe the ACA has changed that a little bit because now we can get it through the, what's it called, the marketplace. See that? But up until the ACA, it was a thing that you got through your work. I think almost all of us, maybe I even have the number here. I think I want to say like 70% of us, 60, 70% of us get our health insurance through our work, right? That, that's not an inevitable natural thing that came from somewhere, and it came from this early 1940s tax loophole that worked well enough that it became the predominant way that we would receive health care here in the United States. And so that took off and grew, and it supplanted, that is to say, it didn't replace because we didn't have it before, but it supplanted the need or the urgency or the clamor for some kind of free universal health care. Because in the middle 20th century, we were doing pretty damn good. Real incomes were good and they were growing, and we were getting good raises every year. We had good benefits. We had strong unions. We were pretty equal. It was it was a good period for workers. So there was not a strong clamor during that time for us to move to a system of universal health care. And then in the 60s, Medicare and Medicaid are created. But of course, there are some problems with this basic idea of employer-sponsored health care, one of which is obviously the better the job you have, the better your health care is going to be, for the most part, right? And the worse your job in terms of wages, in terms of prestige, in terms of safety, in terms of security, the worse your health care is going to be. So it's not like universal health care in that it reproduces a fundamental inequality between different types of workers in our economy. And then the other piece is, and this is kind of perverse when you think about it, but it's a perversion, it's a sort of contradiction that's built right into the system of employer-sponsored health insurance. And that is, if you get so sick that you can't work, you lose your health care, right? So universal health care would address that. It would produce a safety net that if you were so sick that you couldn't work, you'd be caught in that safety net. But employer-sponsored health care, or health insurance rather, like we have in the United States, doesn't catch you if you fall through that particular crack. So that takes us up to the 1970s, or to the 1970s. And then in the 1970s, And this is, of course, a simplistic rendering of what is a very long and complex history, but, for our purposes, our heuristic purposes here, we can go ahead and do this. In the 1970s, things start to change. Dun 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 dun. Those words up there are that's organ music. If you were wondering what that is, that's you. If you were wondering how you should read the title of this slide, it's 1970s to 1980s. Dun, 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 dun. Just like that. Okay, 1970s, things go a little haywire. Okay, we experience in our country some economic shocks, the 1980s as well. So in the 1970s, for example, the oil crisis happens. You've got a shortage, a global shortage of oil and oil rationing, and people, waiting in lines around the block to be able to fill their gas tanks. And so oil is very expensive. It's very hard to come by. Everything gets much more expensive. That leads to what economists call stagflation. And then and it led to a boom in grain prices, in primary goods, agricultural prices. I mean, I guess primary resource commodities across the board. It created a bubble, a price bubble for those things, and that price bubble popped in the 1980s. And so lots of people that had, put everything into the farm or something like that ended up with a lot of debt that they couldn't handle. So we had a massive farm crisis in the early 1980s. And so there were a lot of economic shocks during that time. At the same time, you have that market ideology, the ideology of the unfettered free market becomes more and more widely accepted and appreciated, and it becomes, in many ways, the predominant political economic ideology in the United States. That has a lot to do with Ronald Reagan, has a lot to do with Margaret Thatcher in the UK. And at the same time, late 1970s, we see the early stages of economic globalization. And so now the cost of transportation and technology and importing and exporting has become low enough that we start moving factories and that sort of thing overseas. And that picks up steam in the 80s and 90s, obviously. But it really has its roots in the 1970s. And so also in the 1970s, we see the beginning of a growing divide, a growing chasm between the rich and the poor in the United States. Whereas from the 1910s maybe to the 1960s, we saw, let me see, how can I pantomime this graph here? We saw like a convergence, not a total convergence, but maybe some amount of convergence in terms of incomes, right? So the working class was better off all the time, and so inequality was decreasing for the first half of the 20th century. And then from the 1970s forward, we start to diverge again. Inequality rears its head again, to the point that it starts to look like the 1870s, right? The so-called Gilded Age. And so all of these things, all of these phenomena taking place in the 70s, late 70s through to the mid 80s for the most part, begin the process of degrading the quality of employer-sponsored healthcare in the United States. So this is where the story of U.S. having really shitty healthcare kind of has its historical origins. And so the full neoliberalization of healthcare takes place from the 1980s to the 2000s, really, in the latter part of that era. And this has to do in part with the rise of HMOs, which I think stands for like Health Management Organization. But you know what HMOs are? They're groups, collectives of healthcare providers that, you have a health insurance plan in which you can only receive care from that specific group of providers. And what that is designed to do is to bring costs down. And but what it really does is it limits to a large extent the choices that the consumer has or that the patient has. And it also has a tendency, particularly when we moved from nonprofit HMOs to for-profit HMOs, it has a tendency, because we're trying to control costs, to have the effect of also providing pretty shitty health care. And if you ever had to be on the phone with like a customer service representative, really shitty customer service. And then in the 2000s, you see the rise of other market-based, market-oriented neoliberal measures to deal with healthcare, like, for example, the health savings account. And a health savings account is a tax-deductible savings account that you can put money into that your employer can match in some instances, for you to have a fund, a set of money set aside for you to buy your health care. And the idea is that this way you are spending your money on your health care. And for free marketeers, that's a good thing, because only you know exactly how much healthcare you need, exactly how much healthcare you want, and so you have all of that flexibility with a health savings account. Of course, what it means is that, as with employer-sponsored health insurance, but at a much more magnified level, you get what you pay for. So the poorer you are, the less access you have, the sicker you will be. The better off you are, the healthier you will be. And so it reproduces that kind of inequality, and it treats healthcare, again, like a commodity, like a private good. Healthcare in the United States is no different from an automobile or a computer or a television set. If you can afford it, you've got that BMW. If you can afford it, you've got that, I don't know, what's a big number of inches for a plasma screen? I don't know. Anyway, you have the nice things. And if you can't afford it, you have the shitty things. And so we've moved over time, over the course of the 20th century, and then much more quickly in the first 2 decades of the 21st century, we have moved towards more and more responsibility on the shoulders of the individual consumer to provide for their own health care, which reinforces more and more inequality, and has degraded the quality of healthcare. And we'll talk about that too, because it isn't just the type of health insurance, but it's the way that insurers interact with primary care practices and hospitals and that sort of thing that conspires to create a system in which the quality of healthcare is just inferior, right? And so we've seen over the last 20 years, deductibles are getting higher, co-pays are getting higher, and our service is getting worse. I'll just tell you, my insurance went up last month. I got the notice. It's going to go up by over $800 a year starting in June. So, and I mean, that happens almost every year. So that's the story of healthcare in the United States. So this is worth debating. We all know what a public good is now. We've studied that. So is healthcare a public good? Do we deserve to just have as much of it as we want? Is it ethically the same thing as education? as shelter, as national security, right? These are all public goods. Everybody has the same amount. If you're richer, I mean, if you're, if you're if your annual income is 10 grand or 10 billion, your national security is exactly the same, right? So we have decided that national security is a public good. What about healthcare? Should it be? Should it not be? It's a question worth asking. So there is, as you might imagine, some debate about it. Cheers. There's some debate about it. Okay, so here are some arguments against, or let's see, for treating healthcare as a public good. Arguments against providing healthcare through free markets. Well, a lot of people want to point out that healthcare isn't like a TV or a car. It's a fundamentally very different thing because it's really risky and it's really uncertain, okay? So when you go into surgery, you are putting your life in somebody else's hands. You are trusting an expert, a highly trained, as we assume, and highly qualified expert with your life. That's very different from buying a television, right? The level of risk is much lower. There's also what economists would refer to as asymmetrical information, and that has to do with the expertise, the medical expertise. We don't know shit about our bodies and our health. We have to trust doctors because we are total ignoramuses. When you go to Best Buy, you probably know, well, I don't know, they know some shit at Best Buy, but you probably know like a solid 85% of what the people at Best Buy know about, smartphone platforms or something. Not the case when you go to the hospital. You do not know 85% of what the surgeon is going to do to you when he performs a, triple bypass on you, right? And so there's asymmetrical information. So this is another thing that makes healthcare fundamentally different from most commodities, from most things that, economists would call like consumer durables, like a car or a TV or a computer or something like that. And then there's this other piece, which is the economic development piece. The economy depends on us. The economy needs us. We are its lifeblood. We are its plasma. We go to work and we do things and we get a paycheck, and that's good for everybody, right? If none of us went to work, the economy would collapse. I mean, we've seen that. Lots of people aren't going to work right now, and it fucking sucks. You can't buy toilet paper. You can't buy pork. You can't go out to eat. There's a lot of stuff we can't do right now because the economy is like half broken, right? So the fact that we work keeps the economy and the society and the world running in the way that it does. And guess what? What you think? Well, here it is. If you're sick, you can't work. If you're dead, you can't work. And so healthcare, but you know what? You can still go to work if you don't have a car. You can still go to work if you don't have a computer. You can still go to work if you don't have a TV. But you cannot go to work if you're dead. I promise. I tried once. It doesn't work. And so in that sense, healthcare is different from the rest of these commodities, right? And then there's the ethical piece, which shouldn't need any explanation. you may feel differently than I do, and that's okay. But it does seem to me at a fundamental level like everybody has a right to be healthy as possible, right? It just seems wrong to me that richer people should have better access to health. Uh, it just seems wrong to me. That's just me. Maybe you have a different idea. That's cool. Um, and I think that the current pandemic, the current infectious disease shitstorm that we are all in the midst of, that is swirling around our heads, it helps underscore the argument that healthcare ought to be a public good. So what has happened, and we're going to talk about this in more detail in a few moments, but what has happened is that hospitals and primary care practices are profit driven in a commercial healthcare market. And that means that they have to find the right balance, the optimal balance between resources and patients, because they don't want to have more. Let's use the example of hospitals and beds, and we'll talk about this in more detail in a minute. But like, you don't want to have more beds than you need, because then that's money down the drain. So you need to study exactly how many patients you're planning on having and have exactly that number of beds, right? And so you've got this incentive structure set up to not allow for the possibility of an epidemic or a pandemic, right? And that is a function of, to a certain extent, a private healthcare system. Now, we have seen, to be fair, Italy. Okay, Italy has free universal health care, and Italy also kind of sucked at managing the coronavirus. There are definitely some differences. Italy is very dense. It's much older than we are, both in demographic terms and in terms of just the structures, the country. It's been around a hell of a lot longer. So there's a lot of different reasons why Italy sucked at COVID, even though they have free universal health care. So this is not a simple story of U.S. bad, rest of the world good. It's not a simple story of commercial healthcare bad, public healthcare good. It's more complex than that. Okay, I've given you some arguments about why healthcare should not be a commodity, why it shouldn't be distributed through free markets, but there are some reasonable arguments on the other side too. So let's consider them, and then let us make an educated and reasoned, let us each individually come to an educated and reasoned decision about what we think, and then pretend that you agree with me so that you get a good grade on your paper. So here's the counterpoint. Here's the devil's advocacy. And Adam Gaffney, in the article that we read, refers to this as the moral hazard argument. And it makes sense in some ways. It is a logical argument. And it goes like this. If healthcare were free, everybody had unfettered access to healthcare, then we would just use too much of it. We would go to the doctor when we didn't really need to, right? Everybody would be like your first child. When you have your first child, you take that thing to the doctor. I mean, if it just like looks at you weird, you're like, doctor, right? If it's got a little bleeding, if it loses a hair, doctor. Take that thing to the doctor every 5 minutes. And so the idea is, if healthcare were free and universal, we would use it more than we need to. These so-called sniffle claims, right? Whenever we have a cold, we would go to the doctor instead of just toughing it out. Whenever we stubbed our toe, we'd run to the emergency room, right? And of course, what happens is, or what the argument goes, if that happens, if we have free healthcare and then we use too much of it, the moral hazard argument, then the government, because the government's providing it, is paying a lot more for the universal healthcare than they need to, right? And who ultimately pays the government to pay for the universal healthcare? The taxpayers. And so with free universal health care, it's going to end up wasting a lot of money because we're going to be going to the doctor when we don't need to. And so the whole country is going to have to cough up for a really expensive medical system, universal health care system, that ultimately could be, if it were private, much more efficient and streamlined. Okay? So that's part of the argument. The other part of the argument is, and this one is in some ways I think maybe a little bit less meritorious, but the other part of the argument goes like this. Different people have different levels of desire to consume healthcare and different levels of need, right? So one person is just sickly. They're just born bad. They get sick all the time. Well, they need to go to the doctor all the damn time. Me, on the other hand, I'm robust. I'm vigorous. I eat spinach by the can. And so I never need to go to the doctor, right? And so I would rather use that money to take a vacation. I'd rather use that money to remodel my house rather than use that money to go to the doctor, because I just have the good fortune of being vigorous, right? So different people need different levels of health care. Different people want different levels of health care, right? There's two pieces there that we need to parse out. One is the need. I'm a robust person, you're a sickly person. And one is the want. I would rather buy a TV than some antibiotics. You would rather buy antibiotics than a TV, right? So different people have different desires, different things that they're interested in consuming, and then different levels of need in terms of the healthcare that they want to have access to. So a private system, an employer-based system, or an individual system where we save money and use that to spend on healthcare, that allows us to make those kinds of choices. But what happens is, of course, as we've said multiple times so far, it leaves a lot of people out. It leaves a lot of people out. And so you have sick people that need health care that cannot get it. And it turns patients into consumers. And then we become consumers of healthcare. We comparison shop for who's the best doctor and what's the best plan and so on and so forth. And it really does fundamentally come down to a moral choice. Is this something that everybody has a right to or not? All right. So let's talk a little bit about hospitals in the time of COVID-19. So we have seen this really weird, paradoxical, perverse, and frankly tragic thing happen, where we've got this global pandemic. I don't know if you've heard about it. A little thing called coronavirus. Crowny, I like to call it. So there's this little global pandemic thing, all the people and the death and the ventilators and stuff, right? And at the same time, and so you've got situations like New York City where people are dying in the hallways in hospitals. They're just laying in the hallways waiting for someone to die so that they can get access to a ventilator. We've talked ad nauseum about the refrigerated trucks, right? But, lines of refrigerated trucks full of dead bodies because the morgue can't handle them all, right? So crazy stuff, crazy stuff. We've never needed, at least not in 102 years, more urgently as many capable health care professionals as possible as we do now. We have never, in 102 years, have never been this desperate for as many healthcare workers as possible, right? Duh. And yet, since COVID-19 has started, we have fired tens of millions of healthcare workers, nurses, med techs, doctors, surgeons, fired tens of millions of healthcare workers since COVID-19 started. That makes, in my humble estimation, zero fucking sense. Okay? So why? Why do we have a system? How did we arrive at a system that is so perverse that during the middle of the most urgent global pandemic in 102 years, we are firing tens of millions of medical workers, right? Interesting. Well, what happens is hospitals are losing a metric shit ton of money right now. Hospitals are losing, by one estimate, 60 to 90%, depending on the hospital, 60 to 90% of their revenue. So if you run a business and you wake up one morning and have lost 90% of your revenue, you're going to be firing some people, right? So why have they lost all of this revenue? Well, hospital revenue comes from hospitals operate under a fee-for-service model, which means that if you need a service, you pay for that particular service, right? And in most cases, the hospital and the insurance company share the fee for that particular service, right? Because the insurance company is going to cover part of it. So the insurance company makes some of the money, the hospital makes some of the money. But when elective procedures are concerned, and this is broadly defined, right? I mean, in the podcast that we listened to, they mentioned appendectomies as being elective in some cases, and for example, reconstructive surgery for a woman after a double mastectomy as elective, right? And I think many folks would consider neither of those elective. Both of those are pretty essential to one's well-being. So elective is interpreted pretty broadly here, but elective is basically anything that the insurance company isn't going to pay out on. And so the hospitals derive the vast majority of their income from elective procedures. And what has happened is hospitals have had to turn to dealing with almost exclusively COVID-19 cases. And so they've had to turn away elective procedures. My beloved mother, for example, has been trying to get in to have her toe looked at. Her toe's all bungled up. And she's been trying to get in to have her toe looked at for months, and she can't get in to have her toe looked at. And so that represents revenue losses for the practice that's going to look at her toe, right? And so private practices, primary care practices, specialist practices, and hospitals are losing money hand over fist right now. And so they're having to fire people. And so in the middle of this pandemic, when we desperately need more workers, when we don't have enough healthcare workers, when people are dying in the hallways because there aren't enough people to see the patients, we're firing tens of millions of people. And that is because of this fee-for-service model. So what happens is, under a system like ours, the only one, as I've mentioned at the top of this lecture, in the rich world that has a system like ours, for better or for worse, under a system like ours, the maxim for hospitals is they are run like businesses. They are paid for service, right? So they are incentivized to be lean and austere operations, right? So you think of a hospital as being a very wealthy institution. Well, we've learned in the wake of this crisis that many hospitals, particularly rural hospitals, many hospitals aren't well off, don't have money in reserves, are living hand to mouth, and are barely making ends meet. And so they weren't able to weather this shock particularly well. And so hospitals have to be efficient. Hospitals have to make a profit. And under a fee-for-service model, making a profit means performing as many procedures as possible, right? As many tests, as many exams, as many surgeries as possible. And so this leads hospitals to make a kind of cost-benefit analysis of what each bed in each room is costing them, right? Because a bed costs them money. Not just the purchase of the bed, but you've got to clean the bed and change the sheets and keep the lights on and clean the room and you know, attend to the patient and so on and so forth. And so each bed costs money. So a hospital doesn't want to have many more beds than it's going to have patients. It's better to have fewer beds than patients, as long as it's just a little bit fewer, than to have more beds than patients if it's going to be many more. Does that make sense? So a hospital is incentivized to have the optimal number of beds, which does not allow for a surge in capacity, right? So a hospital is going to go along thinking, well, you know, average over the years, we're getting, you know, 72 patients a day on average per month. So that's what we're going to, you know, budget for. And then when we get slammed with the global pandemic that nobody was really expecting, although they should have been, and we'll talk about that later, then all of a sudden they don't have the capacity to absorb that. And it's because they haven't been incentivized to have excess capacity, right? Because they are profit driven. If they weren't profit driven, if they were public, if the goal were health, if the goal were universal health for everybody, then it would make sense for the hospital to keep an extra 20 beds, even though they're empty almost all of the time, even if they were empty every year for 102 years. It would make sense for them to have those extra beds, because you never know when a whole bunch of people are going to get really sick, right? But if you're incentivized to you know, maximize your profit margin, then you're incentivized to cut costs. And that doesn't allow for maintaining that excess capacity to absorb extra sickness in the time of a pandemic, because it's just not cost effective to do that, except for every 102 years. Does that make sense? So this fee-for-service model, it creates a set of incentives, for better or for worse, where the revenue, hospitals' revenue, comes from procedures that they perform. And this is the case for for-profit hospitals as well as for nonprofit hospitals. But what this means is that it incentivizes hospitals to be reactive rather than proactive. In other words, the hospital's primary goal is never going to be my overall health as an organism. Rather, the hospital's primary goal is going to be to treat that one particular ailment that I'm seeking treatment for, right? Because it's too expensive under a fee-for-service model to keep me healthy in a general sense as an organism. But it's in their interest to keep me needing more and more services, needing more and more procedures. And so that is, I think, economists would call that a perverse incentive, right? So you're paying for the doctor to perform an action, perform a procedure, rather than to produce health. Does that make sense? So the other way to handle this, to avoid that particular perverse incentive, is what's called a global budget. And the VA, for example, has a global budget from the federal government. And a global budget model basically says, boom, this is the amount of money that this institution has to keep your people healthy, and period. And so now, all of a sudden, that totally flips the incentives. And now the financial incentive is keep that motherfucker as healthy as possible, because every time he comes back, he's costing us money. Whereas with the fee-for-service model, the incentive is, I don't really care if he's healthy. Let's keep him coming back because we get paid every time he comes back. But with a global budget, it's boom, here's your budget. It's not going to change. This is the money, this is the amount of money that you have to do what you want with. Keep your people healthy. And now their goal is to keep me healthy. And because the fewer times I'm back, the better off they are. The more I come in, I'm taking up time and I'm taking up resources under a global budget model, that's costing them money, right? So universal health care has a global budget model. It is not the most cost-efficient model. It is not the cheapest model for the taxpayer. It does, however, provide a more holistic health. It provides equal health to everybody. It allows for a medical system infrastructure to build into it excess capacity to absorb extra sickness in the case of an epidemic. So even though it is not the most efficient and not the most expensive, or not the least expensive for the government and the taxpayer, it is in many demonstrable ways a superior model. And we don't have that here. Every other country like us, wealthy, affluent, quote-unquote developed country has it. We don't. Part of the reason why we don't is, and this takes us full circle back to the beginning of this lecture, part of the reason why we don't is because of our employer-sponsored healthcare model here in the United States. Companies that pay insurance companies to cover us as part of a benefits package don't want universal health care, and the insurance industry certainly does not want universal health care. It signals the complete implosion of the insurance industry, and so there's a lot at stake, and it's a very difficult, to use a physics metaphor, turning the ship. Isn't that a thing people say? I don't know. Maybe I'm saying it wrong. But you have like a gigantic yacht. You can't just turn it on a dime, right? Well, our medical bureaucracy, our medical industry is a gigantic yacht that you can't just turn on a dime. And particularly when the insurance industry and the medical industry, as Gaffney pointed out in the article, the organization that tanked universal health care during who succeeded Roosevelt? Herbert Hoover? Harry Truman. Thank you. Yes, Harry Truman. The institution that tanked universal health care during the Truman administration was the American Medical Association, right? So the medical industry doesn't want it, and the insurance industry doesn't want it. We'll see what happens. Will COVID bring about a change? in the United States in terms of how we manage healthcare? We shall see.